Okay, I'm going to tell you a little story. 20 years ago, after my PhD, I've been trained as a physicist, was doing nanotechnology, and I thought, what I'm going to do with my life? I was in my bath and thinking, and I thought, why not changing the physics of a cell? So that's the question I asked myself, and after my PhD, I went to SUNY at Buffalo, and I started to make experiments, and the first experiment I have done is taking a cell that was expressing some specific receptors on the nucleus. I've built some magnetic nanoparticles, and I have added on the surface some specific targeting agent that will target the nucleus of this cell. And I also added some luminescent molecule on the particle so I could follow the particle and see the particle. So I mixed that, the cells, the particles, and I looked in a microscope with some light so I could see the luminescence coming out from the particles. And every green spot you see here is coming from the particle and the luminescence from the particle. And I took a magnet and I made the magnet spin like 50 centimeters away from the cell. And I've been able to spin the nucleus of the cell from the outside with the nanoparticle. So that may seem completely useless, which is, I should agree, but that was the beginning of the story of nanobiotics. And when I did this experiment, I thought, yes, it's possible to take particles, to send them into a cell, and to change the physics of these cells. So it was the foundation of what became, after that, nanobiotics. And that's why today we intend to change the face of cancer treatment for millions of patients by bringing nanophysics into the heart of a cell. And we started by looking at what is one of the most used tools in oncology and found out that radiation therapy is used for more than 60% of all cancer patients. Nevertheless, it's not always curative, and we found out, discussing with many MDs, that if radiation has limit, is because sometimes you can deliver the dose efficient enough to kill completely the tumor, and eventually the patient may die from local invasion of this tumor if it's in a sensitive organ. Or, at the time of radiation, patients are already metastatic, and radiation today is mainly, alone, made to solve local problems. Another problem is how can we help the patients that are cured with radiation or local treatment but still have a number of side effects by decreasing the dose. So when you look at radiation, it's a very powerful tool, but there's still some limitation that could be overcome. That's why we ask ourselves, how can we increase the dose in the tumor without increasing the dose in surrounding tissue? And we thought that if we can answer this question, then we'll change the life for millions of patients. And for that, we have developed a technology which is based on crystalline inorganic nanoparticle. That's not a drug. That's a nanocrystal. So it's an injectable that you will inject only once directly into the tumor prior to the first session of radiation therapy. So why nano? Because we need something which is small enough to go into a cell. And just to give you an idea about the size of this object, if you take one of your hair, you cut the diameter in 3,000, and you have the size of the particle that we manufacture. So those particles, small enough, they go into cell. But being nano is not enough. They have been designed for two things. First, to be inert. That's why we have chosen a very stable and inert material to limit toxicity. But more importantly, they have been designed to absorb X-ray. And physics says that if you use dense nanoparticle with a lot of electrons, you will absorb a lot of X-ray. That's why we have chosen hafnium oxide, which is an inert and heavy loaded on electron nanoparticle. So how does this work? You see a cell here irradiated, and when you send X-ray into a cell, you will create some random damage. Increasing the dose of radiation will increase the number of random damage. Now, on the right side, you see nanoparticles that have penetrated the cells. In the picture you see upper right, you see some dark spot. Every day, there are hundreds of nanoparticles that have penetrated the cell. And when you do irradiation on those cells, the particle, they will absorb the energy and will deliver locally a large quantity of energy and will destroy more efficiently the cell. So there is here a fundamental difference with regular radiotherapy. It's not only increasing the number of random damage, it's locally delivering a high dose of radiation. It means that it will make much more damage in a different way than radiation can do. So obviously that's a physical mode of action, just like radiation, and which is very tumor agnostic, that could be used across oncology. So this physical destruction of cells has some consequences, like direct cell death that could lead to a better local control in many clinical situations. But we also proved recently that by using this particle on top of radiation, we largely increase the immunogenic cell death or activation of the STING pathway or other immune-related activity that will mobilize the immune system to start killing the tumor and potentially a distant metastasis. So we've started this program by developing what we think is a hard-to-crack indication, soft tissue sarcoma, locally advanced soft tissue sarcoma, in a neoadjuvant setting. So we went from phase 1 through market approval in Europe, showing in a phase 3 that this new mode of action works into human. And I will come back to that in a minute. Now, we're focusing the whole energy we have to go for head and neck cancer. And you will see why we go to head and neck cancer and what we have done and where we are going in the coming that should run globally very soon. But as I said, this product is tumor agnostic, so our intention is to go across oncology. That's why we have a large clinical program going to prostate, rectum, other head and neck indication alone or in combination with cisplatin. We have a large immuno-oncology program also where we combine this with checkpoint inhibitors, especially for refractory patients. And we have signed recently a large collaboration with MD Anderson that will run 9 clinical trials in different indications. So just before we move to head and neck, just would like to emphasize some of the results we obtained in soft tissue sarcoma, and those data have been published in Lancet Oncology this summer. So that has been a randomized phase 3 clinical trial where 180 patients have been treated. So here we talk about locally advanced sarcoma in lymph or trunk wall. So those patients, if we want to have an efficient local treatment like surgery, radiation therapy could be beneficial because you will increase the ability to have a good surgery, but also increase the cell killing that could reduce the likelihood of this tumor to make metastasis. So that's why we're using in this population this product and radiation in the standard of care. So we've been comparing radiation alone plus surgery versus radiation plus nano plus surgery. We've been randomized 1-to-1 patient, around 180 in 2 arms, and the primary endpoint, as per EORTC definition, has been linked to complete pathological response rate. Endpoint, because in soft tissue sarcoma, this is supposed to be linked to overall survival for the patient, as long as R0 surgery is linked to overall survival. So in this trial, as per ITT-FAST evaluation, we've seen that when we compare the control arm versus the tested arm, we've been multiplied by 2 the rate of complete pathological response, going from 7.9 to 16.1. And when we look at the grade 2 or 3, the most advanced patient in this trial, we've been multiplying by 4 the rate of complete response. Other secondary endpoints have been achieved too, with a statistical difference like R0 or others, that shows that clearly this product into human has provided some benefit compared to radiation alone. In terms of safety, we've seen that for both arms, we've been able to deliver the same standard of care, the same dose of radiation, no more surgery complication in one arm versus the other. The only noticeable toxicity we found is at the time of injection, in less than 10% of the patient, we found an acute immunological reaction, but no single chronic toxicity linked to this product, which was quite consistent with any indication we have done so far and any patient treated across 15 indications.